All right, let's jump right into this explainer. Today, we're looking at a pretty incredible workflow called ViBrowns. It uses NotebookLM to transform static, de-identified clinical cases into a totally dynamic engine for long-term clinical reasoning. Seriously, if you've ever read a fascinating case study only to completely forget the core lessons a week later, this is going to change the way you learn.
So, the big question we're starting with is this. How do you actually extract years of wisdom from just a single de-identified patient case? Because let's be honest, the traditional way we read case reports is way too passive. You read the presentation, you skip to the final diagnosis, maybe nod along, right? But that doesn't build any actual clinical muscle memory. We need to figure out how to take one single document and just squeeze every ounce of physiological reasoning and clinical judgment out of it.
And that brings us to our core mission, which I absolutely love. Don't let takeaways stay trapped in one notebook. We're going to build a system where your learnings actually accumulate over time. Instead of leaving all your hard-earned insights stuck in some isolated doc or a random PDF you'll never open again, this workflow forces you to extract specific, tagged pearls of wisdom. And these pearls compound, case after case, into a permanent, fully searchable database.
So here's our roadmap for the ViBrowns workflow. We're mapping this out chronologically, right alongside the natural progression of a doctor's training. We'll hit setup and grounding, look through the intern lens, step up to the resident lens, synthesize everything into a pearl bank, and finish off with some SOAP note practice.
Starting right off with setup and grounding, let's see exactly how this workflow establishes our baseline from ground zero.
Okay, so what's really fascinating here is how rigorously we have to constrain NotebookLM right out of the gate. When you set up your notebook, you upload the de-identified case report as your one and only source. And before you do any analysis whatsoever, you run a grounding prompt. You're basically forcing the AI to confirm the basic patient data, map out the exact sequence of events, and explicitly flag any obvious gaps. You are setting the strict rules of engagement here.
And this is absolutely crucial. We want the AI to spot the gaps, not hallucinate fake medical facts to make the story sound better. If you normally want a specific piece of data at presentation, but it's just not in the text, NotebookLM needs to literally tell you, not documented. That's a correct answer, not a failure. That is exactly the behavior we want.
Now that our data is firmly grounded, we move into the intern lens, where it's all about mechanisms and building that scaffolding.
I want you to notice the massive shift in cognitive load here. Thinking like an intern means your focus is entirely on the what and why. It's about mechanism, recall, and scaffolding. You are building the foundation. That contrasts really sharply with the resident lens, which is all about judgment, deviation, and those nuanced what-ifs. And the rule of thumb? You can't successfully tackle the resident tier until you've totally mastered the intern tier.
So for this intern lens, we feed NotebookLM some highly specific prompts to unpack the case. We ask for a super crisp, 3-sentence summary of the history. We extract the active problem list, the meds, and the top 5 most abnormal labs, complete with their normal ranges for context. But honestly, the real magic happens with the jargon and mechanism prompt. We ask the AI to act like it's teaching a brand new intern, defying every piece of jargon and explaining the actual physiological or pharmacological mechanisms behind the tests and treatments. We don't just want a list of what was done, we demand to know why it works. Another huge part of this tier is the blind differential drill. We tell NotebookLM to use only the initial presentation data. We strictly forbid it from peeking ahead at the final diagnosis in the document. Based on that really limited day one information, it has to list the differential a clinician should be considering. And critically, it has to list the dangerous can't-miss mimics, those things that present similarly even if the case ends up being totally benign. This is what enforces completely unbiased clinical reasoning right at the starting line.
Once we've got those mechanisms locked down, we graduate up to the resident lens, diving into judgment and nuance.
At this stage, we assume the baseline mechanisms are known. We're turning up the complexity. We force the AI to map out the actual decision points. We're asking, where could reasonable clinicians have taken a totally different path? We want to know where the management deviated from standard guidelines, and we need to know if that deviation was justified by something atypical in the patient or if it was just a classic pitfall. These resident-level prompts are rigorous mental drills. You're not just listing differentials anymore, you're ranking them. You're forcing the AI to provide one piece of supporting data and one refuting piece of data directly from the text for each condition. You track how the probabilities shifted as new lab results came in, and this is my absolute favorite part. You have NotebookLM play devil's advocate. You literally tell it, challenge my leading diagnosis, give me the absolute strongest argument for why an alternative might be right. It forces you to actively defend your clinical choices.
And then there's the overnight deterioration drill.
This is incredible. You prompt the system to imagine the patient suddenly deteriorated overnight, based strictly on their real trajectory in the source notes. It tests your hypothetical crisis management, like what bedside check do you do first, what immediate step do you take right now, at what point do you escalate care. It's phenomenal practice for on-the-ground decision-making, but it's still constrained entirely by the reality of the documented case.
All right, moving on to synthesis and Pearl Bank. Let's talk about extracting that permanent wisdom. Before we extract our final takeaways, we run a consolidation prompt. You explicitly ask NotebookLM, what did the resident lens add that the intern lens completely missed? By comparing the outputs of both lenses side by side, you actively see how the reasoning evolved. It's a great metacognitive step that helps you zero in on the absolute most critical takeaways from the entire session.
And the ultimate output of all this synthesis is your Pearl Bank. You have NotebookLM extract 2 to 3 intern pearls and 2 to 3 resident pearls, and you have it format them into a very specific table. It categorizes everything by organ system, topic, pearl type, and then the actual text. Over time, as you grab these rows and paste them into a master spreadsheet, you are building a highly searchable, personalized database. Your knowledge literally compounds with every single case.
You've probably noticed the strict structural difference between the two types of pearls here. The intern pearl is mechanism anchored. It's about foundational rules. This finding leads to this action because of this mechanism. The resident pearl, on the other hand, is judgment anchored. It's all about advanced clinical nuance. This situation means deviating from the standard approach when this condition is met because of this underlying reasoning. Having both formats ensures you remember not just the rule, but exactly when you need to break it.
Finally, we hit SOAP note practice. This is all about disciplined documentation. This final prompt takes all that raw, messy reasoning we just did and translates it into a standard clinical SOAP note format. We ask the AI to generate the subjective history, the objective vitals and labs, the assessment, and the plan, all based strictly on the case material. It's an awesome self-check to make sure you can clearly separate your objective data from your subjective assessment leaps. Plus, it really trains you to distill complex reasoning into clear, professional documentation.
Now we absolutely have to end on this vital reminder from our source material. This incredible workflow is strictly for educational observation. We are using de-identified data. These outputs are learning observations, never actual clinical decisions. But by applying these intern and resident lenses, you're transforming static reading into active, rigorous discovery. Which leaves us with one final question to think about. How are you going to build your own Pearl Bank starting today so your hard-won insights never get trapped in a closed notebook again?